On today's Doctor is In, we are talking about prostate cancer.
And here's Casey's interview with Dr. Scott Ackerman about the importance of screenings.
Prostate cancer is the #1 cancer diagnosis in men. In recent years, there's been some controversy about screening guidelines for this type of cancer. Dr. Scott Ackerman is one of the first coast's leading oncologists. He is here today to walk us through the latest screening guidelines and treatment options. Dr. Ackerman, thank you so much for being here.
Thank you, Casey. It's good to be here.
Once again. Okay, so this is really an important topic, and we want to dive into what are the current screening recommendations right now for prostate cancer.
Okay, for patients that are going to be screened, I recommend a combination of both the digital rectal examination and the prostate-specific antigen, the PSA test. So the digital rectal examination is when the physician examines the prostate with his or her finger to look for a nodule or something, and the PSA, the prostate-specific antigen, is a blood test that looks at elevation of an antigen that might be related to the fact that you have prostate cancer. And so my recommendation is, and there's some controversy about recommendations, but I recommend that all men who have a life expectancy of at least 10 years and are over the age of 50 get screened on an annual basis. But if you're at high risk for prostate cancer, meaning either you have a strong family history of prostate cancer, a father or a brother who's had prostate cancer, or if you're of African American descent, where the incidence of prostate cancer is nearly double that of non-African Americans, then I recommend those screening tests be done at a younger age, and my recommendation is starting at age 40.
Okay, let's say we get this screening, and in the screening it indicates that there's a possibility that we could get prostate cancer, or that how is that confirmed? How do you then go about, I guess, what's the next step?
So if the digital rectal examination is abnormal, meaning we feel a nodule, and or the PSA is elevated, and I've seen cases, all three, where the digital rectal examination is abnormal, but there's a normal PSA. I've seen the digital rectal examination be normal with an elevated PSA, and of course there's instances where both are abnormal. If either one of those or both are abnormal, then there's a risk that you may have prostate cancer. And so we recommend a biopsy typically. But with biopsy comes some risks. There's risks of bleeding, urinary problems, infection. So there's a new test out called PCA3. PCA3 stands for prostate cancer antigen 3, and this aids in the diagnosis of prostate cancer and helps us identify who should be biopsied and who maybe we could just keep an eye on. And what we do is we excrete some prostatic fluid into the urine. We express it into the urine, and then we collect the urine, and we test that. We then get a urine specimen, and we separate the prostatic fluid from the urine, and we test the prostatic fluid for certain genetic abnormalities, and we look for these biomarkers in the urine. And if there's overexpression in the prostatic fluid that we get from the urine, if there's overexpression of the PCA3 antigen, then there is a higher likelihood that a biopsy will be positive. Conversely, if there's not this overexpression of PCA3, then a biopsy could be avoided, and we could save men from having an unnecessary procedure.
Well, that's what I was going to say. You know, if you have this screening, it's positive. If there is a chance of having, or if you do have prostate cancer, surgery isn't always necessary. And this biopsy isn't necessary. You almost have to keep an active watch on it, I guess would be a way to describe it.
I think that screening, biopsy, and treatment all have to be done intelligently. I don't think you can have a blanket statement that no one should be screened, or everyone should be screened, or no one should be biopsied, or no one should be treated. This needs to be done intelligently. And I suggest that all men discuss treatment options with their physician, because not all men need treatment for the prostate cancer. If someone is older, and the tumor is of a low stage and low aggressivity, meaning we looked at it under the microscope and it doesn't look very aggressive, men like this are excellent candidates for active surveillance. Now, active surveillance, some people, we used to call it watchful waiting, but really it's active surveillance, meaning that you're seeing frequently by your physician, you're having close follow-up, you're having tests done on a regular basis, the PSA test, to see whether it's going up or down or whether it's stable, and periodic biopsies of the prostate, annually or less often than that if need be, to evaluate whether or not this cancer has dedifferentiated or become aggressive. So if it's a small volume of tumor and it's a low aggressivity cancer and the man is older, or a combination of those things, then those are good candidates for what we call active surveillance.
If you do need treatment, however, what are some of the technologies, the newer technologies that are available to get this taken care of?
Well, the traditional technology is surgery to remove the prostate, radiation treatments to irradiate the prostate, and also hormonal treatments. Some patients we just put on hormonal therapy, which blocks testosterone from stimulating prostate cancer from growing. But there's some newer options with surgery, the robotic prostatectomy, which is really, really neat because the surgeon can go in, remove the prostate in a much less invasive way. Men recover much more quickly and go home more quickly. There's also proton therapy, which is an interesting way of delivering radiation to the prostate, where we get a good, nice high dose of radiation to the prostate and much less radiation dose to other structures, and hence less side effects. But the bottom line is there's these different treatment options, and you really need to discuss with your physician what's best for you, understanding your age, your health, and other medical problems you might have. And it's very important to understand the risks and quality of life and the side effects that go along with any kind of treatment that you may have.
All right, Dr. Ackerman, as always, thank you so
Casey.
much for being here. We appreciate your time and for sponsoring this segment. And for all of the good advice, as always, you can reach out to Dr. Ackerman and do so on his Facebook page. If you have any questions, if you have any concerns, you can weigh in on the Facebook page and they will respond. And again, that Facebook page is facebook.com/First Coast Oncology.